I have to take just 1 minute to say, how much this reflects Bruce's sort of evolution in the last 30 years that I've known him. He has been the most selfless leader in giving to the development of young investigators in this field, and to finding new answers for patients through better understanding of the biology, all the way from pharmacokinetics and resistance of methotrexate to the molecular biology of IDH mutations. And so it's really sort of fitting that we have these tremendous talks today. So as I said, we're going to continue on the theme of signal transduction. The first, inhibiting signal transduction in cells. The first one actually addresses the issue of sort of the dirty compounds in terms of inhibiting more than one pathway in trying to treat tumors. And since most tumors are heterogeneous, we think that in the end, this is going to be critical. And to better understand, what's happening in the inhibition of MET and VEGF, I'd like to introduce Matt Smith, who's one of the leaders in the GU program here at MGH and a true international expert in sort of the inhibition of MET and VEGF receptor in prostate cancer. Matt?
Thank you, Jeff. Really appreciate it. The generosity that Jeff referred to of Bruce's mentorship is really extraordinary. My career is in many ways an example of Bruce's generosity. So Bruce, thank you for your mentorship and for including me in this colloquium. The translational research is really bidirectional. It's bench to bedside and bedside to bench. And I'm going to describe the development of cabozantinib in prostate cancer as an example of that kind of bidirectional translational research. And cabozantinib is a dirty tyrosine kinase inhibitor. We prefer multi-targeted to dirty. It depends on which perspective you look at. But its development in prostate cancer really rose out of some interesting fortuitous observations in the clinic. So there's still a role for fortuity. There's a variety of ways I could describe this story, but I'll choose a narrative that doesn't bore you with the historical details, but kind of presents where we are in the development of this drug. And I'll begin by just describing the compound. This is cabozantinib. It's a multi-targeted tyrosine kinase inhibitor. It has a variety of molecular targets listed here. It's often shortened to be described as a dual inhibitor of MET and VEGF receptor 2, but you'll see that it has a variety of other molecular targets, including, very importantly, RET. And this is where the story begins in many ways, because RET plays a central pathophysiologic role in medullary thyroid cancer. And the first area for drug development for cabozantinib was, in fact, in thyroid cancer. Here's the design of the pivotal exam trial. The drug showed activity in phase 2 in medullary thyroid cancer. And this led to a randomized controlled trial of cabozantinib in medullary thyroid cancer, a large undertaking, 2-to-1 randomization of cabozantinib versus placebo with, importantly, no crossover. This was a spectacularly positive trial, hazard ratio for progression-free survival of 0.28, so more than 70% delay or improvement in the risk for disease progression, highly statistically significant. And this has led to a new drug application for cabozantinib in medullary thyroid cancer. And the FDA will act on that application sometime this calendar year, so we'll hear a lot more about that. And because of the lack of a crossover in this study, there will be an opportunity to evaluate the impact of cabozantinib on overall survival, which will distinguish it potentially from other agents that have been developed in this disease. So what about prostate cancer? So why study a thyroid cancer drug in prostate cancer? So let me just briefly describe some of the clinical features of prostate cancer that will make this more understandable. So as many of you know, prostate cancer is an important clinical problem. More than 250,000 new cases in the United States annually, about 30,000 deaths per year. And critically, bone metastases are a uniform feature of fatal forms of prostate cancer. This is a typical bone scan of a man with metastatic prostate cancer. Metastatic prostate cancer is primarily involves the skeleton, and bone metastases are associated with important clinical complications, including pain, fractures, spinal cord compression, and ineffective hematopoiesis. Men with fatal prostate cancer primarily die a skeletal death. And the biology of bone metastases is complicated and different than many other types of metastatic disease. And one of the characteristic features is that it forms primarily osteoblastic rather than osteolytic metastases, and has a particularly high levels of bone turnover. So think about this bone scan. This is a typical bone scan of a man with extensive metastatic disease. And you're going to see a lot of these pictures repeated because one of the striking observations with cabozantinib is that it dramatically improves detectable disease by bone scans. It's important also to begin with a brief description of the dramatic changes in the treatment landscape of prostate cancer. This is basically the timeline since 1994 in prostate cancer, looking at all the meaningful approved drugs. Drugs above the horizontal line have all been approved based on increased overall survival. The 3 drugs below the horizontal line are based on other outcome measures. Mitoxantrone was approved in 1996 for palliative benefit, and then 2 bone-targeted drugs, zoledronic acid and denosumab, were approved in recent years for prevention of disease-related skeletal complications, so a supportive care type of therapy. We now have 5 approved drugs based on increased overall survival. The first drug was approved in 2004, and then you see this clustering of other agents in the past couple of years. A few really important comments here. Many of these drugs act by completely different mechanisms. So docetaxel is a chemotherapeutic agent. We have cabazitaxel, another chemotherapeutic agent, sipuleucel-T, an immunotherapy, abiraterone and enzalutamide, 2 highly effective hormonal agents, both of which increase survival, and radium-223, an alpha-emitting bone-seeking radiopharmaceutical that's expected to be approved by the FDA in 2013, also based on increased overall survival. So a lot of progress in the field with multiple new agents, many of which act by different mechanisms. It also makes for a particularly challenging path for new drug development with these many approved therapies in advanced disease. Now, there's a reasonable rationale for targeting angiogenesis in prostate cancer, and it's summarized here. First, VEGF, expression of VEGF receptors correlates with higher grade of tumors and poor prognosis in advanced prostate cancer. VEGF is present in localized and metastatic prostate cancers, and higher plasma concentrations of VEGF correlate with disease progression. And in men with metastatic castration-resistant prostate cancer, higher urine and plasma concentrations of VEGF are associated with worse survival. Here's making this latter point here. This is a Kaplan-Meier survival analysis according to baseline VEGF levels above and below the median. And you'll note that the men with higher levels of VEGF have a worse overall survival. So this background really formed the basis for evaluation of a variety of VEGF-targeted therapies in prostate cancer. The experience to date, though, with VEGF-targeted therapy, with angiogenic-targeted therapy, has been very disappointing. And here's a list of the failed trials, all phase 3 trials. So bevacizumab in combination with docetaxel prednisone, the standard first-line chemotherapy, showed no improvement in overall survival with a modest improvement in overall survival, modest improvement in progression-free survival. Not clinically important, but statistically significant. A couple of other agents have been looked at in combination with chemotherapy, lenalidomide and aflibercept, both of which showed no improvement in the primary outcome of overall survival. And then sunitinib was studied as monotherapy, meaning not in combination with chemotherapy, in men with metastatic CRPC. Also showed no improvement in overall survival, but a modest improvement in progression-free survival. I'm going to expand a little bit on the data from the sunitinib trial because it'll provide meaningful introduction to the idea of studying cabozantinib in advanced disease. So this is the design of the phase 3 sunitinib trial in metastatic castration-resistant prostate cancer led by my colleague Dror Michelson. It included about 900 men with metastatic prostate cancer. Most of those men had bone metastases and disease progression despite standard androgen deprivation therapy, a terminology that's commonly referred to as castration-resistant disease. Subjects were randomized 2-to-1 to sunitinib or placebo. All patients received prednisone in both arms, and they remained on study until they had clinical disease progression. as you can see here, there's a modest increase in progression-free survival. This was a statistically significant improvement, but this delay was not felt to be clinically important. And the study failed to meet its primary endpoint of overall survival benefit, and accordingly has not been developed further in prostate cancer. So this is where it gets interesting. So sunitinib and cabozantinib in many ways are remarkably similar. They have a number of the same molecular targets, VEGF receptor, RET, and KIT, but the really big difference here is that cabozantinib inhibits MET. What I've done here also is to summarize some of the activities that were observed with sunitinib in phase 2, and this will provide an important point of contrast when you see the data from cabozantinib. So resist responses, meaning bidimensional measurable disease responses with sunitinib, were rare with sunitinib, and the effects on bone biomarkers were very weak, very minimal effects. And in retrospect, when we looked at the activity of sunitinib, there were some improvements in bone scans, but they were relatively rare and for the most part modest. And you'll see that fairly striking difference pattern of activity when I show the data from cabozantinib in the same disease state. There's a strong preclinical rationale and clinical rationale for evaluation of a dual MET and VEGF receptor inhibitor in prostate cancer. Bone metastases are the major cause of morbidity and mortality in advanced disease. MET is highly expressed in bone metastases, and osteoclasts and osteoblasts express both MET and VEGF receptors and respond to the corresponding ligands, HGF and VEGF. And both HGF and VEGF appear to direct crosstalk between tumor cells, osteoblasts, and osteoclasts. In other words, these pathways appear to have an important role in both tumor growth and progression. They may have a separate role in normal bone biology as well as the important interactions of tumor and bone in the setting of metastatic disease. Cabozantinib has been evaluated in a broad variety of different diseases, and this was done in the context of a large randomized discontinuation trial. This is a busy slide, but I'll briefly walk you through it. So the drug was studied in 9 different diseases, all listed here, including breast, ovarian cancer, prostate cancer, and a number of other malignancies. The notion was that the drug may not result in dramatic tumor regression, but might result in disease stabilization. So it was studied using a randomized discontinuation design. All subjects were treated with the drug for 12 weeks and then evaluated at week 12. If they had progressive disease, they came off study. Those with complete or partial response in bidimensionally measurable disease continued on an open label extension. And then it was thought there'd be a large group of patients with stable disease who would then be randomized to either continue the drug or cross over to, or to placebo. And then at disease progression would be unblinded and cross over to open label drug if they had been assigned to placebo. The main observations of the trial showed that there was activity in a fairly broad number of diseases, including breast, ovarian cancer, and prostate cancer. In separate trials, the drug has activity in renal cell carcinoma. I'll leave all the discussion of those other diseases to a different time and now focus on the activity of the drug in prostate cancer. Because of early observations of disease activity originally made by Maha Hussein and David Smith at University of Michigan, the study accrued a large number of patients, a total of 171 subjects in the RDT. These are the baseline characteristics of the subjects. By design, all the patients required measurable disease, which is not the most typical feature of advanced prostate cancer. If you look at an unselected group of men with metastatic castration-resistant disease, only about 1/3 of those men would have measurable disease. And because the activity I'm about to describe in bone was not known at the time, there was no requirement for bone metastases in this particular trial, although, as you might expect, about the majority of patients, 87% of patients, did in fact have bone metastases. These were a fairly extensively pretreated group of patients. More than 40% had received docetaxel, and a large number of patients had received other therapies, including abiraterone and/or enzalutamide, then known as MDV-3100. The resist response rate was relatively low at 7%. The majority of patients had stable disease. And there was a high rate of non-progression at week 12 of about 70%. Although the resist response rate was low, about 3/4 of the patients had some measure of improvement in their measurable disease. If you look at the inflection point of this waterfall plot here, all these patients had improvements in bidimensionally measurable disease, although again, the resist response rate was relatively low, not an uncommon feature in this cancer. And you'll note, too, that these improvements in measurable disease were found regardless of extent of prior therapy. Orange bars represent patients who had prior docetaxel. So you see a lot of activity even in the most extensively pretreated subjects. Here's where it gets really interesting, though. In our field, there's really no expectations typically that bone scans would improve even to our best therapies. And the striking observation here was that a high proportion of patients, in fact, the majority of subjects had improvements in their bone scans, with 56% had partial resolution and almost 20% who had complete resolution of bone disease. And only 3% of patients had progression of bone metastases as their best response by bone scan. Here are some striking examples of these findings. These are fairly representative examples, all in each case pre and post bone scan. So if you take this case and the second patient, extensive sites of metastatic disease throughout the axial and appendicular skeleton with near complete resolution of bone disease after just 12 weeks of treatment. This is not a metastasis, that's normal bladder uptake. Similar marked improvements in a variety of other patients represented here. You'll note, too, that some of these responses were seen in patients who had prior docetaxel treatment. There were corresponding symptomatic improvements in many patients, including reduction in narcotic use and decrease in pain scores. This is a patient we treated at MGH Cancer Center, and it's very important for a few different reasons. One, it makes the case about this improvement in bone scan, but also shows that this is a reversible effect. So patient with extensive metastatic disease, all these hot spots throughout his skeleton, on study, and you see resolution of those sites and metastases. Again, you can see his bladder uptake throughout. Improvements in bone scan do not constitute resist response. There is no criteria for a response in a bone scan. So his technical categorization on the study was stable disease, and he was randomized, in this case, to placebo. 6 weeks later, bone scan progresses. He's crossed back over to Cabozantinib, and you see, again, the re-response. And this will be really important, and hopefully we'll have an opportunity in the question and answer session to talk about that kind of activity. Here's the same patient, pre and post-treatment, same dramatic improvement in his bone scan. And what we see by CT is this increased sclerosis or mineralization of his bone at a site of this bone metastasis. In other clinical settings, increased mineralization or sclerosis is seen as a sign of healing. Remains to be determined if that same biology is true here. Now, there are a number of other supportive indications of meaningful benefit in this setting. There were pain improvements in the majority of patients. There were, among patients who required narcotics, there were also reported pain improvements, and many of the patients decreased or discontinued narcotic use during the course of the trial, with all of the usual caveats of an open-label phase 2 study. Now, this is a multi-targeted tyrosine kinase inhibitor, or as Jeff said, a dirty TKI. And like other TKIs, the drug has associated side effects. In this study, the starting dose was 100 milligrams per day. And at week 12, more than half of the patients required at least one dose reduction. And with longer follow-up, more than 80% of patients who remained on study required one or more dose reductions. The most commonly reported adverse effects were fatigue, decreased appetite, diarrhea, nausea, sort of the typical side effects of other TKIs with a similar profile of target inhibition. So that raises some really important questions about optimal dose, particularly in a drug which we believe would require chronic therapy, at least as suggested by the reversibility in that case example. So really striking pattern of activity, a profile of clinical activity that had not been seen with other drugs in this disease. But there's a number of important caveats about interpreting this data. First, bone metastases were not required for eligibility. The observation about these dramatic improvements in bone metastases does have a reasonable molecular explanation, but in fact was a fortuitous observation in this trial. Similarly, there is no standardly accepted criteria for bone scan response. So in many ways, the description of the bone scan improvements is post hoc, not pre-specified in the study. The randomized discontinuation design was designed to capture clinical activity and in many ways was effective at that, but it has limitations then about interpreting the subsequent data due to crossover. And the other supportive outcomes data that I described, including improvements in pain and narcotic use, also were not pre-specified and should be interpreted carefully in an open-label trial. So in an attempt to address some of the limitations of that experience, we expanded the trial to a non-randomized extension cohort. In this part of the study, all the patients had bone metastases to build on the observed activity in the earlier study. There was a more uniform cohort of particularly treatment-refractory patients. That really does reflect the changing treatment landscape of the disease. If there's a path forward in this crowded clinical landscape, it would be in a fairly refractory disease. And we prospectively defined and centrally reviewed assessments of bone scan changes. In fact, in many ways created the definition of bone scan response for the purpose of developing this agent. The primary endpoint for this part of the study was bone scan response, and we prospectively defined assessments of the other supportive outcome measures. So here are the baseline characteristics of the 93 subjects who were treated on this extension cohort. All the patients had bone metastases, more typically reflecting a broad population of patients with advanced prostate cancer. Less than half had measurable sites of disease. A lot of the patients came into the study with pain and/or narcotic requirements. All the patients had received prior docetaxel and progressed within 6 months of that treatment. More than a third of the patients had received abiraterone and/or enzalutamide. So this really, in many ways, defines the most treatment-refractory population ever prospectively studied in prostate cancer. That will change over time as we have more drugs, but to date, this is one of the more treatment-refractory populations ever studied. And then a number of the patients, in fact, the majority of patients were receiving concurrent bone-targeted therapy with either zoledronic acid, a bisphosphonate, or denosumab, a RANK ligand inhibitor approved to prevent skeletal-related events. The patients come in with, as you'd expect, a high burden of disease with a median PSA of about 194 and a median CTC count by Veridex of 49, really a lot of disease. This, too, is similar to the prior experience. The drug had a similar profile of adverse events, and in this experience, more than 80% of the patients required one or more dose reductions. And in this study, there was continuous dosing. There was no interruption due to randomization. And that'll lead to some important considerations about optimal dose, and I'll describe some important work in that area at the end of my presentation. So to facilitate the rigorous evaluation of this effect we'd seen in bone scans, a computer-assisted detection method for bone scan lesions was developed, and this was work of Jonathan Golden at UCLA. They used CAD imaging to and then normalize the images and annotate areas of bone metastases. And then we prospectively defined a bone scan response as a 30% improvement in bone scan lesion area. And this slide just summarizes some of the technical aspects of this method, and this has been FDA cleared for evaluation in clinical trials. This is a summary of bone scan response using this more rigorous and prospectively defined method of assessment. More than 2/3 of the patients had a bone scan response, with 4% having a complete response, 62% partial response. Only 8% of patients had progressive disease as their best response in bone. And the median duration of response is summarized there. This is a waterfall plot of the change in bone scan lesion area, the primary outcome for the trial. Again, you see the striped bars representing the fact that the patients had improvements in bone scans really regardless of the extent of prior treatment. All the patients in this group had received docetaxel and progressed despite that chemotherapy treatment. And you'll see in the yellow bars a number of the patients who had received, in addition to docetaxel, abiraterone and/or enzalutamide. And you see many of the responses occurring in these patients with the most highly refractory disease. This is change in measurable soft tissue lesions. Bearing in mind, fewer of the patients had measurable disease in this study. But again, you see this very nice waterfall plot with the majority of patients having some improvement in measurable sites of disease separate from bone, although, again, a relatively small RECIST response rate of less than 10%. Now, what I haven't said to date, and may be wondering is, what does this do to PSA? In prostate cancer, we focus a lot on the issue of PSA, and the observations have been consistent in both the randomized discontinuation and in this extension study that PSA changes are often discordant with other metrics of anti-tumor activity, meaning there's a relatively low PSA response rate, and many patients who have improvements in bone scan and or measurable disease may either lack a PSA response or in fact even have a paradoxical PSA increase. So this raised lots of questions about what's going on. In an attempt to better understand the relative contribution of various potential activities of this drug to the clinical observations, we looked to CTCs as an independent way to assess potential anti-tumor activity. And this is a waterfall plot for change in circulating tumor cells in the trial. You'll recall that patients came in with very high levels of CTCs with a median count of 49. By the Verdex method, greater than 5 cells is defined as abnormal. Nice waterfall plot, very few patients showing an increase in CTCs as their best response. Most of the patients, vast majority of patients having improvements, and the majority of patients meeting this 30% cutoff of improvement in CTCs as one metric of clinical activity, 92%. The median best CTC change was 86%. And then among patients who had greater than 5 CTCs at baseline, categorized as abnormal, about 40% of those patients converted to normal by week 6. So this provides some independent evidence of an anti-tumor effect, particularly important, I think, given the PSA changes that I described. These are changes in pain scores among patients who entered the study with baseline pain. High proportion of patients with improvements in pain, many meeting a cutoff of greater than 30% reduction in pain scores. Now, I described some interesting preclinical and clinical observations that suggest MET and VEGF receptor are important in normal bone physiology and in tumor-bone interactions in an attempt to better understand the impact of cabozantinib on bone. Specifically, we looked at bone biomarkers. On the left is CTX, a marker of osteoclast activity. On the right is BSAP, a marker of osteoblast activity. Again, waterfall plot showing that changes over time, pre and post treatment. Nearly all patients have reductions in CTX and BSAP. A fairly unusual pattern of activity. We have other drugs that target bone, for example, zoledronic acid or denosumab, target osteoclasts specifically, and might have comparable effects in an untreated population, but those drugs have little or no effect on osteoblast activity. So here we see a drug that has fairly dramatic effects in both osteoclasts and osteoblasts, including dramatic effects in patients who are already receiving potent osteoclast-targeted therapy. So the patients shown in yellow are patients already receiving denosumab or zoledronic acid, a potent bisphosphonate. So having done a lot of work in the past in the bone field, if we look at these bone biomarkers by themselves, this drug would become one of the more interesting and exciting drugs to look at as a bone-targeted therapy. This shows progression-free survival. This is, of course, very sensitive to methods of ascertainment and other limitations of reporting progression-free survival in a phase 2 trial. So I show it primarily just to show patterns of progression. And you'll note that most of the progressions tend to be in soft tissue with bone not driving the progression in these patients. Now, so here we have an interesting sort of situation, fortuitous series of observations showing a high level of clinical activity, a pattern of activity that's not been seen with other drugs in this disease, but a fairly substantial amount of adverse effects and a requirement for dose reductions in the majority of patients. So we asked an obvious question, and that is, can we preserve clinical activity at a lower dose, a dose that might be more amenable to chronic dosing and treatment of patients with advanced disease and who are already experiencing a variety of toxicities related to their disease? So in an attempt to do that, we conducted an investigator-initiated dose-finding study, used the Sargent 3-phase design. The notion is that you come in at a starting dose, and then using predefined methods of cutoffs for response. If you have a high level of response, you go to a lower dose in the next cohort. Low level of response, you go up in a dose level. And then depending what you see in the second dose level, you expand the cohort to increase your confidence about the activity you've seen. So 3 dose levels, and you intend to study 2 of them. And the dose levels are shown here. Our starting dose was 40 milligrams. Again, the starting dose in the prior studies was 100 milligrams, so 60% dose reduction relative to the prior experience. The primary endpoint was to evaluate the lowest effective dose of cabozantinib in patients with metastatic CRPC, and we defined benefit or activity as a bone scan response in the same manner as we used in the extension cohort, with secondary endpoints to look at a variety of other outcomes, including bone biomarkers and circulating tumor cells. Here's what we saw in the first cohort. These are bone scan responses. You see, just go to the punchline here, high rate of response by bone scan, very nice waterfall plot. All the patients treated at 40 milligrams had improvement in bone scan lesion area, and all but one met criteria to define a response. And with subsequent follow-up, those responses were durable. There is a real, here's some examples, just to show you the nice pictures. Here's these are quantitative changes here. 78% improvement in bone scan in this subject, complete resolution of bone disease in the second subject, and then this patient with very extensive metastatic disease, 97% improvement by week 6. There is a real dose response here, and at the second lower dose level, 20 milligrams, you see a fall off in this waterfall plot. We do see some activity, but far less than we see at 40. We then expanded around the 40 milligram dose level. Here's the expansion cohort again, showing a high level of activity in bone scan response. So we take this to mean that doses as low as 40 milligrams retain much of the activity, if not all the activity, seen at higher dose levels. When treating patients at this dose level, no one required dose reductions by week 12. The pattern of adverse effects was similar, but substantially milder than patients treated at a higher dose. So we also wanted to be sure that we got this right and not rely entirely on bone scan response to assess activity. So we were also very interested in looking at CTCs and collaborated with Dan Haber's lab to do both the standard Veridex CTC method, which I'll describe, and then do some additional translational work to look at other methods for capturing CTCs and that would facilitate molecular analyses. So CTCs, as I alluded to before, are categorized as poor prognosis if they have a cutoff of greater than 5. And so we'll show you all the data, but the main effect we're looking at here is normalization for those patients with greater than 5 CTCs at baseline. 12 of the 21 evaluable subjects had greater than 5 CTCs in blood, and 92% of those, of all the subjects had a best CTC response of greater than 30%. So here's some of the data. Looking at waterfall plot of change in CTCs from baseline to week 6 or 12, showing the best response. Similar to what we saw at higher doses, only one patient had an increase in CTCs as his best response. All the rest of the patients had improvements in CTCs, obviously smaller numbers than in the larger multi-center experience, with many of these patients meeting criteria for CTC normalization. So collectively, this has been really interesting development of cabozantinib. There's been a series of observations, some of them fortuitous, some of them much more directed about the drug in prostate cancer, and I've summarized these observations here. So at a starting dose of 100 milligrams, which is where we have most of our experience with this drug in prostate cancer, there's at least preliminary evidence for clinical activity. The majority of patients have improvements, in some cases complete resolution of disease on bone scan. The majority of patients, about 80%, have regression of measurable sites of disease, although the RECIST response rate is relatively low. There's other supportive evidence of clinical activity of this agent in prostate cancer, including improvements in pain and narcotic use in symptomatic patients. And while the PSA changes are often discordant with other metrics of anti-tumor activity, the observations of CTCs suggest that cabozantinib does have direct anti-tumor effects. We believe that the preliminary evidence from our single institution investigator-sponsored trial supports the activity of cabozantinib at lower dose, specifically at 40 milligrams, and that those observations have informed the design of many other phase 2 and phase 3 trials in prostate cancer and other diseases. We've defined the starting dose for most of those trials as 60 milligrams. Why 60? It's really not more complicated than 40 plus 1 dose level, such that if patients require dose reduction, they'd be at a dose that we believe would still be active. Cabozantinib has side effects like other TKIs, and that, of course, has driven the work about looking at optimal dose. And collectively, this body of clinical research has led to a phase 3 study called COMET-1. I'd like to echo the comments of Jay Bradner. Enjoyed your talk very much, and I believe he said in conclusion that any drug that's really important should improve overall survival. I believe that, we believe that, and are studying that exact question in the COMET-1 trial. This is a large randomized controlled trial of men with highly refractory prostate cancer with the primary endpoint of overall survival. I took a moment to show that complicated landscape slide because the field has changed dramatically in the last couple of years, and a major unmet medical need remains in those patients who progress despite chemotherapy and these new highly active hormonal agents, and this is the exact population we'll look at. The patients in this study will be metastatic CRPC with bone-only or bone-dominant forms of metastases, which is the majority of our patients in our practice, and who have progression despite prior docetaxel and progression despite either abiraterone and or enzalutamide. There's no limit to prior therapies, and as I said, all the patients will have bone metastases. The primary endpoint is overall survival, in an attempt to understand and validate this outcome of bone scan response. That'll be a key secondary endpoint. That study is open and accruing patients, and we hope to be able to report back to you about the results in a couple of years. I'd like to conclude by thanking many people who contributed to this work, my close clinical colleagues at MGH, Rick Lee, Dror Michelson, Phil Saylor. We've had great experience of collaborating with the Haber Lab and doing some of the work on CTCs, and there are many more molecular analyses that we hope will come out of this, and a variety of rational ways to better understand the activity of this drug in this disease. We have a great collaborator in MGH imaging with Umar Mahmood. And then I mentioned Jonathan Golden at UCLA, who's developed the method for bone scan assessment that I described. I'd also like to thank my colleagues at Exelixis who've been key in the clinical development of this drug, particularly Ron Weitzman. Thank you.
Thank you, Matt, for an incredibly insightful summary of a very complicated area. So I'll ask you one question, and then we'll open it up for additional questions. What sort of is going on to try to figure out the role of MET, VEGFR, RET, anything else in the overall response, given the multi-targeted nature of this agent?
Thanks for your question, Jeff. So if you've concluded it's complicated, then I think you've got it right, because it is complicated. And there's a variety of ways to think about this. One is that given the high rate of activity, say, for example, by bone scan, it can't be a rare patient population with MET amplification or overexpression alone that accounts for this activity. And the other thing to note is there are a variety of activities. So it has a high rate of improvement in bone scans, almost uniform, I would submit. There are very few patients who have progression as their best response. And yet, there are far fewer patients who have dramatic improvements in measurable disease. So these may be different mechanisms at play. And to further complicate that, there are other metrics of activity, such as, say, improvements in CTCs. We do have, I described PSA changes as discordant, but it's not entirely accurate. If the small group of patients who have PSA responses uniformly have improvements in bone scans and measurable disease, is that there are some patients who have improvements in the latter but don't have improvements in PSA. So there's a lot of things at play, and it's going to depend on which outcome you look at. And then the other part is that the drug, data I didn't show, has independent potent effects on bone. It doesn't require bone metastases to have these marked effects on bone biomarkers. So teasing these issues out is going to be very challenging. I showed that summary slide of sunitinib and cabozantinib. I don't know if that'll come up again, but the drugs are remarkably similar, except that cabozantinib inhibits MET. So it's hard to imagine that, but yet the clinical activities are quite strikingly different. So it's hard to imagine that MET doesn't play some important role in this profile of clinical activity. Having said that, I'm prepared to consider all kinds of explanations for this. But I'd also would rather trade a drug with clinical activity for a drug with certainty and no activity. So I'm happy to have lots of questions about this.
Bruce,
Yeah.
Is there evidence for HCG or hepatocyte growth HGF production? Is there any evidence for HGF production by the tumor or stroma?
Yeah, the answer is both to yes. Yes to both, excuse me. Yes to both questions. HGF is thought to play an important role in normal bone biology, in tumor-bone interactions, and some prostate cancers express HGF. So that's part of the rationale for studying MET. The corollary to this is, well, what about specific MET inhibition in prostate cancer? That's a question that has not been well studied. There's a peptibody against MET that Amgen was developing. They did a trial, not been reported, but I guess we can take that to mean there was little activity, at least in the way the study was conducted. There are small molecule inhibitors of MET, but I've heard no anecdotal reports of this kind of activity. This is hard to miss. I mean, this is really hard to miss. So we went from, telling patients, your bone scan will only get worse typically, right? We don't expect to see a bone scan response, to on this drug saying, we fully expect you'll have a bone scan improvement. So this is a hard activity to miss. So if pure MET inhibition does this, we'd be surprised because it just hasn't been reported yet. It is also worth noting this is not a prostate cancer-specific phenomenon. I think it's the phenotype of prostate cancer that pulls this out because it's bone dominant in most cases. We see activity like this in breast cancer. Jose and Baselga and Michaela Higgins here are doing a very nice study in breast cancer and seeing some very nice activity, including in patients with bone metastases. The drug has activity in other malignancies, including renal cell carcinoma.
When CTCs are measured, are they alive or dead cells? And does it make a difference?
So thank you for your question. The question was, when we measure CTCs, are they alive or dead? The Verdex method uses EpCAM capture. The cells are not viable when they're recovered. They can't really be studied by this method. So this is purely enumeration that I described. And we chose that. I chose to describe that because it's an FDA-approved test and has been shown in other settings to have prognostic significance. So the level of activity by CTCs that I've shown with this drug is broadly comparable to other drugs that have been approved in prostate cancer based on overall survival benefit. That's a long way from saying that means this drug will improve overall survival, but it's at least supportive data. We're very interested in asking more elegant biologic questions separate from enumeration, and that's why we're collaborating with Daniel Haber using the microfluidic device to recover these cells with the goal of studying both the features that predict response as well as, I think, perhaps even more importantly, changes with treatment.
Would you comment on drug resistance, whether or not you get resistance to the drug? And also, are there any clues as to what drugs seem to synergize or at least add to the effects of this drug?
Two questions. One, is there any evidence of synergy with other agents? This first question was related to resistance. So we've not studied this in combination. There is work ongoing to look at combinations, some of them rational, some of them practical. You have to choose carefully which agents you'd combine it with because it does have side effects like other TKIs. So, for example, combining it with chemotherapy would not at all be attractive. With other targeted agents, including some of the highly active hormonal therapies, may be attractive. The mechanisms of resistance have not been defined. These responses in many cases are durable. We've had patients on therapy for more than a year, but they eventually, most, if not all the patients eventually progress, as you'd expect with other TKIs in advanced disease. And that PFS slide I showed was meant to indicate that patients could progress in either bone or soft tissue. That's meaningful because we wanted to understand the implications to our phase 3 trial. So there doesn't appear to be preferential progression in bone, for example. So we think that is supportive of the proposed study design. Dr. Haber?
When you do see progression in bone, do all sites progress at the same time, or is there some inequality between different sites that would point to different mechanisms? And have you ever gone back to biopsying the bone to see what the mechanisms might be there?
Generally speaking, the progression is uniform. It's fairly uniform, meaning patients don't have isolated progression with durable disease control at other sites. So that may tell us something about mechanisms of resistance. We have not yet done biopsy studies. We've prioritized doing the things that would get us to answer the key clinical questions, including dose selection. And now we're in an interesting phase where we really would like to better understand the biology of what's going on. The drug development questions are important, but I think this agent is telling us a lot about biology of bone and bone metastases and does provide lots of opportunities. It raises lots of questions.
So along the same line, if you compare your drug with other bone stroma target therapy, such as anti-wrinkle inhibitor, what do you find? I mean, non-angiogenic bone stroma target therapy.
So I think the question is, have I compared the activity? So this is, it's like night and day. I mean, the bone-targeted therapies, the approved bone-targeted therapies, zoledronic and denosumab, the rank ligand inhibitor, are osteoclast-specific inhibitors, and they have predicted effects on osteoclast biomarkers, so they lower NTX, and they've been shown to have the clinical benefit of reducing disease-related morbidity. They have no known impact on the underlying malignancy. They do not improve bone scans. They don't tend to improve pain. They have no measurable disease response, no PSA response, no CTC response. So very different. The reason I brought it up and showed the bone biomarkers is, in a way, the activity seen in bone alone is as dramatic, if not actually more dramatic, than what you'd expect to see with the best approved bone-targeted therapies. And we see those effects even on top of the effect of those agents because we've studied it in patients who are already receiving zoledronic acid or denosumab.